Well, hello. I would like to welcome you to the latest presentation in the National Telehealth Resource Center's webinar series. These webinars are designed to provide timely information and demonstrations to support and guide the development of your telehealth program. These webinars are presented on the third Thursday of each month. Next slide. Located throughout the country, there are 12 regional and 2 national telehealth resource centers that form a consortium. We cover all 50 states and some territories in the Pacific Basin. And then the national centers address policy and the technology. Each of us serves as focal points for advancing the effective use of telehealth and supporting access to telehealth services in rural and underserved communities. Just next slide. The few tips before we get started. Your audio has been muted. Please use the Q&A function of Zoom platform to ask questions. They will be answered at the end of the presentation. Today's webinar is being recorded, and you will be able to access today's and past webinars on the National TRC YouTube channel. Next. Today's webinar is hosted by the TexLa Telehealth Resource Center. My name is Becky Bounds, and I'm with TexLa. We serve all of Texas and Louisiana. It is my pleasure to present to you today Dr. Michael Gonzalez, who will present for us. He serves as the Associate Medical Director for the City of Houston Fire Department EMS Division, Director of the Emergency Telehealth and Navigation project that you'll hear about today, Chief of Emergency Medicine at Memorial Hermann, Memorial City Medical Center, and is academic faculty with the Baylor College of Medicine Emergency Medicine Residency Program. He also has an extensive history as a veteran. He is a veteran with the U.S. Air Force. He lectures nationally and internationally with research interests in pre-hospital airway management, telemedicine, and critical care, transport, and trauma. And I would like to turn it over at this time to Dr. Gonzalez.
Hi, thanks, Becky. Thanks so much for the invitation to give this presentation. I am joining you today from Houston, which if anyone is watching the news, you understand we're going through some major weather events right now, so I will apologize in advance if there's any interruption or sound disturbance because some thunderstorm and bad weather is moving through the Houston area right now. So I'll do what I can to minimize the interruptions. As Becky mentioned, I will be happy to answer questions, and I provided my contact information on this slide, and you'll see it at the end as well. So I'm happy, if we run out of time, to follow up any questions via email if that is necessary. So again, I'm here to speak about ETHN, Emergency Telehealth and Navigation, which is our answer to a long-standing problem that I know many communities face, and that is a problem. I use this iconic slide from an iconic movie that I love very much, but every time I use it, I'm reminded by several users that we're approaching, I think it's 28th anniversary, so I probably need to find a more recent reference, but the iconic language remains the same. This Houston, we have a problem. And what that refers to is really a growing number and a growing acuity or a growing challenge in our pre-hospital and emergency department environments with low acuity users. And this is not necessarily speaking of the same problem that many communities have really tried to engage telehealth and a variety of other solutions for their high utilizers. That's a related but a separate problem. What ETHN really tries to go after are those callers who have called 911 for a very low acuity problem, like a stub toe or potentially an upper respiratory type of infection or some sort of low acuity problem that we're seeing really all over the country. So I know many of you have probably seen some of these, and there are a great many other strategies that have used and are utilizing telehealth strategies for exactly this kind of reason. As far as we know, Ethan was the first of its kind to really deploy in the telehealth strategy to the pre-hospital or the traditional emergency medical services or EMS environment. And I'll explain to you a little bit about what we've done and some of the challenges we faced during today's presentation. So just to sort of level set, let me advance the slide here. Just to level set, the city of Houston, 4th largest in the US, there's 2.1 million people in the city proper, 6 million in the region, so 3 or 4 million commute in and out of the Houston region every single day. And that's partly part of the challenge we're facing today with the inclement weather that has taken us sort of a little bit by surprise. All our commuters are downtown, and they're all going to have to get out of town, which is going to face present some challenges for our crews out today. As far as our pre-hospital response system, we are a joint fire and EMS service. So we have 90 plus, I think we're up to 96 fire stations scattered throughout the 660 square miles that constitute the city of Houston. That's just inside the city borders, 600 plus square miles. We respond to, on an average day, 1,500 to 1,000 to 1,500 EMS calls for medical service a day, translating into 600,000 or more calls for EMS service a year. And those translate roughly on a normal day to somewhere between 400 and 500 transports a day. So that was in the pre-Ethan world. That were ambulance transports being utilized, ambulances being utilized for 911 callers upwards of 500 times a day. So that is a scale that is not a lot of communities face, but certainly our brother and sister fire and EMS services in Chicago and LA and some of those big metro areas certainly face a similar or even larger scale. So the problems that we face in Houston are certainly not unique. But I wanted to sort of give an idea of what we were facing and why we decided to build a strategy, particularly around these low acuity callers. Houston for about a decade, and Texas really overall for many reasons, probably the first of which that everybody would know right off the top of their head is the state has no state income tax. So we have a lot of growth in Texas, and that's identified almost universally as the #1 reason for growth in the area. We also have a fantastically low cost of living compared to a lot of parts of the country. So we've really had unprecedented growth for the last decade, and the city of Houston proper was at one point, I believe the statistic was about 1,000 people moving per month, or 10,000 per year, which was really a high growth rate for a major metropolitan area. We've also seen a growth in the number of these lower acuity calls, which I know a lot of you are facing as well. That is not a unique problem to the city of Houston or Texas. Many of you are also seeing the coincident problem as well in their emergency departments, and seeing significant overcrowding issues due to a lot of internal issues, and we'll speak to that in a minute. Couple that with the need for access to primary care, which we all know is a challenge. And I know that there are many fine institutions and some really innovative work being done in the telehealth space to provide primary care to large regions. And we follow those with great interest. But really, as I mentioned, our unique strategy is really applying telehealth to the pre-hospital environment. And as far as we know, no one had ever tried a strategy like this before. So just so everybody is on the same page, again, the patient acuity we're talking about is really the target was this walking well, not necessarily, and I want to carve it out specifically, not necessarily high utilizers. There are a great many, at least in our system, high utilizers that really do have a lot of really significant comorbid medical problems. So I wouldn't necessarily throw them into this group. These are really patients that are, often we have found in our experience, these are patients that are predominantly, they feel like they're disconnected from the healthcare system overall. So I'll give you some demographics in a little bit, but really what we found is that these are patients that really do not have a primary care home. They don't have a connection to a healthcare system or entity that they would consider their primary care provider. And they really constitute a fair amount of our, what we would classify as potentially avoidable, or as the language we used on this slide was unnecessary transports. And when I say that, I want to make sure that I'm clear that there is absolutely a medical need on the part of the caller. And we certainly aren't downplaying that medical need. As the first responder agency for the city of Houston and our millions of patients and constituents, we certainly, we're going to be there. We're there as the safety net, and Ethan really doesn't change the 911 call system, and I'll explain exactly how we do that. But what really our target was these walking well, low acuity users that, based on the work and research done by Dr. Ed Begley at the University of Texas School of Public Health, at one point, and the study based on 2011, 2012, identified that within the city of Houston, based on research of our own 911 callers, upwards of 30 to 40% of those calls, these were 911 calls that were transported to our local hospitals, were identified as having diagnoses that were primary care related. So meaning they went back, did a deep dive into these encounters and followed up to make sure the patients were not only had low acuity diagnoses, but were also subsequently discharged, did not require a significant intervention in the emergency department. So these were really patients that went to the ER, got discharged. I am still, just full disclosure, as was mentioned in my introduction, I am a practicing emergency physician. I still practice emergency medicine at the bedside and can attest that, anybody in the ER at the bedside can attest that it certainly anecdotally feels as well like there's a larger number of these patients coming into our ERs, which presents a challenge in and of itself inside the ER, which brings me to this slide. So again, this is not a new problem. We've seen more and more folks throughout the US really encountering longer wait times, potentially overuse of the ER, not just the 911 system. All of our ERs are facing funding problems, as well as a perceived lack of alternatives. And then internally, the emergency departments themselves are facing problems with throughput, because we also know that in our communities, a lot of times we face hospital bed challenges, and really the biggest impact on hospital, or rather emergency department throughput, is how fast those patients can go upstairs. How many patients are you, quote unquote, boarding? So boarding has really become more of an issue, and really more of a public awareness campaign as well, because emergency departments, believe it or not, are their primary throughput calculation is based on how fast those patients go upstairs. So all of these challenges, again, really have grown to where the EMS system really is a victim. I use this term all the time. It's a victim of its own success. So 911 was born in the US. We know that it is a very successful, highly successful system that we've all come to depend upon, but it really has put a stress on all of our hospital and healthcare systems. And so 911 calls have increased in just about every community. Multiple communities have tried, including the city of Houston, have tried to do public awareness campaigns or PSA, public service announcements, around the idea of what is a quote unquote appropriate use of 911. And that I am aware of, every city that has attempted, at least based on the research that I'm aware of, I should say, every city that has attempted one of those campaigns has always resulted in an increase in the number of overall 911 calls. So those education campaigns, while very well intentioned, have actually had the exact opposite of their desired effect. So with Ethan, again, it's an internal program. So as much as it is a tool that we use to address the needs of our community, it is really not a public-facing campaign. It is really a firefighter, EMT, paramedic tool that we really use for our internal members to try and handle these low acuity calls. So Again, this slide is really meant to sort of represent that the emergency medical system is sort of in the middle of the crosshairs. All these external acts that are contributing to our problems. And again, these are really not unique to the city of Houston. So with Ethan, what we decided is there potentially a way to handle some of these low acuity callers in a way that is less problematic, that is absolutely safe, fast, and easy for our crews? So I've done a lot of research into other emergency medical systems, as well as our own internal attempts on historical programs here at the city of Houston. Before I arrived, a program called Alternative Transportation, or ATP, which some of you may be aware of because the city published on that as well. And that program really focused around the idea of diverting some of these 911 callers, not necessarily at the point of the 911 call. Again, after our crews came out, did a response, did an evaluation, but then connected the caller at the point of the EMS evaluation to an operator or a nurse advice line like triage system. That ended up really being highly problematic for a variety of reasons. But the biggest reason was that that nurse line, and again, this is not condemning a skill set of any population, it really was based on a computer algorithm. So this is not in any way diminishing the skills of my nursing colleagues who I work with at, closely every single day. It was really the computer algorithm was leaning towards a very conservative approach. And you can imagine the reason why. That computer algorithm was really meant for the insurance card in the back of your pocket, to really try and direct people, to guide them about what their medical complaint might be, not based on someone who has already called 911 to ask for assistance. So with Ethan, we knew that we were facing internal challenges because that pre-existing program, or ATP as we refer to it, resulted in an 80% recommendation to transport the patient to the emergency department. So remember, these are people who have already called 911. EMS crews were at their bedside, have talked to them, done a quick evaluation, and now they were on the phone or connected via computer algorithm to this recommendation process, which was resulting in an 80% recommendation to transport. And these encounters were taking somewhere approximately 20 to 25 minutes to complete. For those of you that are very familiar with the emergency medical system or pre-hospital work, you know that a 20-25 minute pre-hospital scene time, particularly for a low acuity encounter, is really completely unacceptable for a bunch of reasons. But most importantly for us, our crews just said, hey, I'm not going to do this anymore. Like, I know that it's going to prolong my scene time significantly, and there's a very good chance that it's going to result in a recommendation that I'm going to transport this patient to the hospital anyway. So knowing that, when we built Ethan, we knew that we had to do something that was faster, that was obviously safe, and could it be done in a way that was easy for our crews to use, remember, utilize every single day. So Ethan was sort of built around those sort of key concepts: safe, fast, easy. So Ethan is really not just the Houston Fire Department. It's really a partnership of various organizations who have come together to work with us, as well as extended organizations, to try and get our patients to ideally their own primary care home, right? Get these patients who I told you at the front this is based on what they tell us, feel very disconnected from the overall healthcare system, and really many have never navigated it on their own, to get them to a primary care home where they can, potentially avoid calling 911 the next time around. So Ethan, although it is run by the Houston Fire Department, is really a partnership of various organizations. So field units, our team of physicians, a Care Houston program that is run out of the Houston Health Department, and then our primary care partner clinics, many of whom are federally qualified health clinics, or FQHCs, who really have come to the table with appointments for us to be able to schedule many of these callers if it's medically appropriate. So I'm going to run through exactly how Ethan works for everybody to understand on a step-by-step basis, to show you what we're doing. So again, Ethan really starts with the 911 call. And I get a lot of questions about this in terms of, have we changed our dispatch system? Do we dispatch a special unit? like a mobile integrated health unit or a paramedicine unit that may be doing some additional work. And I really have to tell, and it comes up very, very commonly when I go out and speak about Ethan, that Ethan doesn't traditionally fit this community paramedicine model that a lot of people are talking about. And there are some, I have had the privilege of going out and visiting some fantastic EMS agencies and services who are doing some really great work with both that MIH or community paramedicine model. And Ethan doesn't really quite fit that traditional framework, and I'll show you why on these upcoming slides. But even at the point of dispatch, Ethan hasn't yet affected the way we dispatch units. So for many of you that are familiar with the pre-hospital world, the 911 operators ask a series of questions, get information from the caller about what that perceived emergency might be. Based on that information, they have a goal of trying to get somebody rolling, crews dispatch, units dispatched within a few minutes of the call. In the city of Houston, from the time the call is received, we try to get someone on scene within around 6.5 minutes, which is sort of the national sort of accepted standard or framework goal, at least for our city size. So again, 911 call comes in, 911 operator takes the information, dispatches the appropriate unit or units. Ethan doesn't really change any of that at this point. So 911 call comes in, traditional response goes out. I use this slide to show that you may get a fire truck. And in the city of Houston, because we're a joint fire EMS service, it is very common to get a fire truck that shows up as the first responder. That is not uncommon in the city of Houston because we have far more fire apparatuses than we do ambulances. And that is true for a lot of joint fire EMS services. So our fire trucks and our fire crews are just about all of them trained to the level of at least an EMT. Many of our fire trucks have a paramedic on board as well. So there's real capabilities on those trucks. The only thing, they have the same drugs, same equipment. The only thing they don't have, obviously, is a stretcher. So those units, very experienced, have a lot of knowledge on their own, do their own field assessment, right? Do their own field assessment, get a focused history and physical, record a set of patient demographics, including vital signs. And then we have a rough set of inclusion and exclusion criteria that I'm happy to share. And then again, I'm happy to answer specific questions. This is often around where most of the questions come from. So some of these may be appropriate to do in this sort of joint setting. Some of them may be easier accomplished offline, but I'll show you what those criteria are here very shortly. But the crew, I want to just stress and emphasize that the Ethan activation is really on the crew that's at the bedside, right? They're in the house, at the scene of the 911 caller, have already done their assessment, and on their own decided, hey, this patient is appropriate for Ethan. And I'll show you these inclusion criteria. We've modified them just a tiny bit from what you're seeing here, but you can see this is not a traditional, complicated, for those of you in the pre-hospital world, complicated EMS algorithm with a set of decision trees and boxes that lead you down a path. I tell you that I struggled when I was creating Ethan to really create that sort of algorithm, and I ended up with a 3-page document that couldn't have been less understandable. So I really struggled with trying to make an algorithm approach to fit it into the traditional EMS box, but it was a little bit like putting a square peg in a round hole. It just didn't work. So what we did is really facilitate the decision making of our crews to say, listen, hey, if this was your family member, would you feel comfortable sending them to an alternate destination, either other than an ER, or if you think they need to go to the ER, do you think they might be able to go safely by something other than an ambulance, knowing that ambulance transports are both limited as well as very costly for our patients and payers who are ultimately subsidizing this work. So these inclusion criteria are pretty straightforward. Most of them have to do with the patient's ability to essentially make their own decisions. So that eliminates a lot of intoxication, overdose. We don't use Ethan for that. And it really, we've extended, there used to be an exclusion that was a pediatric patient. We do pediatric patients now. Number 3, you have mentions an adult patient. We do pediatric patients so long there is a caregiver who has the authority to make decisions for that child. So we transport pediatric patients or use Ethan for pediatric patients now as well. So the Ethan call itself, again, once the crew has decided that this patient is appropriate for Ethan, there's really a very small number of steps that they do. And I'll be honestly, tell you that we're in the process of reevaluating how this works, but I'll show you how we have done the about 25,000 calls that we've completed with Ethan to date. So there's a record transfer inside of our EMR so that it's completely secured, completely HIPAA compliant. They contact the Ethan physician on duty, again, using a completely secured HIPAA compliant teleconferencing application that I'll show you in just a second. We ask that they provide the incident number. That's in the record now. I should have updated the slide, I apologize. And then we ask them to remain close to the patient so that they can hear the discussion with the physician. There are a few times where the physician may uncover something that the crew either hasn't had a chance to ask about or maybe didn't think about. And the crew, often when they hear that information, will step in and say, hey, I know you're going to recommend transport, so we'll start getting the patient ready for that right now. That happened about 20-30% of the time maybe when we launched Ethan 5 years ago. But that is increasingly a very small occurrence now. But we still ask them to stay close by just so that we can have communication with our crews. So our equipment right now, this is a traditional, ruggedized tough pad from Panasonic. There are a variety of tablets and devices out there now that would absolutely satisfy a telehealth requirement. So while Panasonic has been a great partner, I don't want anybody to get the impression that that's the only device that would work. There are many now that would, because it really doesn't require more than essentially a traditional web-based application portal. So this is what we use now. We are in the process of refreshing this equipment. Haven't had an official determination on what we're going to. And then this is what it actually looks like in the field. So our crews, there they are holding the tablet up to the patient who is sitting just off screen. That happens to be me looking and talking to the patient. But we have about 14 or 15 different physicians who work with us on Ethan who answer these calls and help our crews make a determination about, what's the safe, best next step. So again, all of our Ethan physicians are board certified emergency medicine physicians. All of them had at least 5 years of experience, many of them with 15 or 20 like me. And there are people that are actively working in the Houston area, so very familiar with sort of the locations, the services available. Many have an extensive teaching background, and the only reason that I mention that is that we found that one of the biggest benefits our crews have expressed is that they really like hearing from the physician when there's something that he or she may have uncovered. Our crews like to say, like, hey, what was the reason? What were you thinking? And we found that that has really been a highly beneficial part of this partnership, because a lot of the physicians who answer Ethan are not necessarily traditional EMS physicians. So they are not necessarily all pre-hospital work physicians who have done a fellowship there. These are board certified emergency physicians who practice at the bedside. That's really what we needed and what we wanted, because really the determination in terms of the decision that they're making is not that different from what they do every single day in the ER. So again, the physician speaks directly with the patient. Again, as I mentioned, our crews remain close by, but really I want to take special note of what the physician can recommend, right? Under this possible disposition. They can recommend ER by taxi starting from the bottom. They can recommend transport. The patient should be transported by ambulance. They can recommend clinic appointments. The physician, using one of our own portals, has the ability to book directly into a clinic system with one of our partner clinics. We have about 12 of them now, scattered throughout the city. And they can book directly appointments same day or the next day. Now, these are all viable alternatives. We have found in our experience that very often the patients elect to go to the ER. They have sometimes through inexperience, sometimes through experience with the ERs before, have decided, hey, I know I can kind of get my problem solved in one-stop shopping in the emergency department. So we do a lot of that very last category, which is patient sort of elects to go to the ER, even though the physician may have determined that it was clinic appropriate. We're certainly never going to stop anyone from going to the ER, but what we can do is stop them from going by ambulance, because from the fire department, from our fire EMS service, perspective, that's really what we care about. We want to get our crews back in service as quickly as possible. And I'll show you, for those of you, particularly for those of you that may not be experienced with pre-hospital work, why this pre-hospital, these low acuity patients are such a challenge. And I'll show you exactly why we care so much about that here shortly. So again, during the assessment and disposition phase, the physician can book a clinic appointment directly. The physician can also dispatch a cab using the partnership we have with our yellow cab in the region. We can directly book a cab and dispatch a cab all at the same time. What we want to do, obviously, is, as this slide says, we want to address the perceived medical need. The physician may have determined that it's not necessarily or doesn't appear to be a medical emergency, but we certainly understand that we're certainly not in the business of saying, hey, I understand why you're calling, that's not an emergency, you should just stay home. Like, if it's appropriate, we do have some patients that we can walk through that. We do have some patients that call, particularly some very concerned coworkers that may have said, oh, we just saw our colleague kind of stumble down the stairs and they looked a little worse off than we thought. Our crews arrive, they're walking around, they have their own physician. So if it's appropriate, we certainly can direct patients to seek their own primary care if it's medically appropriate. Again, first and foremost, our consideration is to try and do what is safest for the patient. Step 5 is really a navigator piece afterwards, where our Houston Health Department has a set of healthcare navigators that follow up, particularly those patients where the physician has determined that this was safe for a clinic appointment follow-up, but the patient themselves may have elected to go to the ER instead of a clinic. And so we really focus on those to try and do some education, honestly, to try and do a little education, as well as a little bit of follow-up and polling to figure out why it is that they felt like the ER was the best possible use of their time. Because a lot of times we can book clinic appointments within an hour or two of the actual 911 call, meaning that most of them are going to face a longer wait time in the ER if they present there with a low acuity complaint. So Ethan really is a care cycle. It's really interconnected. Our crews have to identify the appropriate patients. Our physicians do their assessment. The clinics have to do their part in terms of receiving these patients if they're appropriate. And then again, we have the appropriate follow-up listed. I apologize. I thought I muted all my devices. I'll do that for this other device now. So we want to make sure that we are appropriately scheduling follow-up and getting our all of our patients cared for in a safe and efficient fashion. So we always get questions about our operational hours. We are striving to be 24 hours a day. We're not quite there yet. We do every day of the week, including weekends and holidays, but right now we're focusing on hours that we know based on our own internal tracking of our patients and 911 calls that we staff the busiest time of the day, which is 10 a.m. to 10 p.m. for these low acuity calls. So we staff, as I said, all weekends, all holidays, and during that time, it may be 3 or 4 different physicians who cover our program because they're doing it from home. And that has really been a significant improvement in our ability to provide physician staffing, because when we first started, Ethan, our physicians were having to go down to the 911 call center in order to be able to take these calls, and we've since upgraded our technology to allow them to answer these calls remotely. So the physicians honestly love doing this kind of work. It's been really easy to get physicians interested in doing it. As I mentioned, we have about 15 who work with us right now, but I have a waiting list of probably 10 or 12 that are waiting for available slots to open up. So for those of you considering doing this sort of work in your, or doing telehealth, I can tell you that's often a huge consideration, a worry, but most of the time that's not a significant limitation in terms of being able to launch a telehealth program. So for many of you, I know what you're most interested in is, has it worked? How has it worked? What does it cost? So we're going to start with this sort of high level assessment of how Ethan has worked for us. I mentioned that we launched Ethan about 5 years ago in the last quarter of 2014. So we are really in our 5th year of operation now. And we are experiencing, have seen really significant operational improvement in our own metrics. And to sort of understand how this works, I'm going to do a brief review of what our HFD-EMS operations were like pre-Ethan, right? So this is a pre-Ethan state. So a 911 call would come in. It shows there an ambulance, a fire truck is the first responder, because that is very common when our ambulances are tied up. So that ambulance then, that fire crew, right, as the first responder in a pre-Ethan world would have to wait then, when there were no other options, they would then have to wait for that ambulance to show up. Remember that the fire truck has already done an assessment, but that other apparatus, the ambulance, has to show up to then transport. So there would be a quick handoff to the ambulance. That ambulance then, of course, would transfer to the ER, because that's the only option available to them. In terms of the way our times work, some of these are maybe a little bit exaggerated, but in a day like today, where we have significant weather, or it happens to be the wrong time of day with traffic, these are not significantly outside of the range of reality. So the numbers below, the first 6 minutes shows our response time, 15 minutes on scene, let's say 25 minutes waiting, 25 minutes waiting for that ambulance to show up, because often our ambulances are in the shortest supply. We have the fewest ambulances compared to other fire apparatuses. There can be a 20 to 30 minute transport time to the ER based on traffic and choice of location, because remember, these are not patients who have a medical reason to go to the closest facility, like a STEMI or a stroke center. Those are not Ethan patients. So patients really get a lot of discretion in terms of where they want to go, and we often take them to the facility, even if it might be inconvenient for the crew. So it can, 30 minutes is not an uncommon transport time. And then 45 minutes at the hospital. This is often called wall time in the industry, right? So our crews show up, they're trying to do a handoff of our patients to the receiving facility. And again, I'm a practicing emergency physician. This is not bashing our ER partners. This is a reality of what happens, particularly from these low acuity callers, where these patients are recognized as, okay, yes, you have a medical need, but I can't take you right to a bed because I have sicker patients that are already waiting in the ER. So often the days of arriving by ambulance brought you right to the front of the line in the ER, that's over. And I know many of you are seeing the same thing in your region. So it is not uncommon for our crews to be tied up at the facility for 45 minutes trying to hand off a patient who may not be that sick. So all told, those numbers add up to exactly 121 minutes. And that's 2 hours of our crew's time, right? Maybe 2 different crews, but still 2 hours of crew time where these guys are tied up for potentially a 911 low acuity call that really may not need the ER, right? So 2 hours of time. And again, this is not average. This is a demonstration of on our end what we know has been true. This is not really based on our own numbers, a significant exaggeration. The actual number is probably close to 92 minutes, our median time for these low acuity calls. So let's talk about now sort of our operational savings and what we've seen now that we have instituted Ethan. So again, the fire truck can be the first responding unit. They respond to that 911 call, they activate Ethan, and then if it's medically appropriate, they can send that patient now via something other than an ambulance. It can be a personal vehicle, or taxi if the ride itself was the reason for the 911 call. And I got to tell you, there's a lot of those patients, right? So now with the taxi being the delivering entity and the clinic being another option, now it's a totally different game, right? So now my crew can leave after their 15-minute assessment, and in general, it takes about 12 minutes for the physician to complete both their encounter and the cab to arrive. It's really about 5 minutes on the Ethan side and 7 to 8 minutes for the cab to arrive. So really, we can do the entire encounter in a dramatically less time. And remember, my crews can leave pretty much after the Ethan assessment is done. So in terms of savings of operational time, it is significant. And we've seen, again, so maybe that was a little bit of an exaggeration, but we found based on our own data as well as an external review of our data that has been published, again, by UT School of Public Health, that it is at least a median 47-minute savings in terms of our crew time for patients that use Ethan that in a pre-Ethan world would have required transport. So a median 47 minutes, of savings in terms of the operational time. Now, many of you are probably very interested in the cost and how this has worked. And I will tell you that I'm going to show you some numbers that are a rough estimate because there is such wide variation in terms of what the actual cost is, right? The cost of an EMS agency to provide the service, the billed, right? What goes out in terms of the bill is very different from the cost, and obviously what gets reimbursed can be different from both of those numbers. So the numbers I'm going to show you are rough guides to just facilitate the discussion, and then we can get into some specific numbers. So again, when we try and measure Ethan's impact on the financial side, we're really looking at sort of the insurer or the patient side as one entity, because a bill will go to either the insurer, the payer, or the patient if they're not insured or underinsured. So for a 911 caller who goes to the emergency department, the total cost somewhere around $1,000 for the ambulance ride, just to make it easy, somewhere around $1,200 for the ED visit, maybe more. And I'm sure many of you are looking at your screen and screaming bloody murder. Yes, I know these numbers are very rough, and I use it purely to facilitate the discussion, right? So ambulance to the ER, a low acuity ER visit, somewhere in the total cost of $1,000 to $2,200. And remember, I showed you that the system, in terms of the EMS system's operational time, somewhere around an hour to 2 hours. And I know those are rough numbers. Ethan, really, if I can take the ER out of the equation and I can get you to a clinic, I can provide exponential savings to that patient and or their insurance company, right? Because if I can remove the ER from that equation, those numbers drop exponentially, right? It is significantly less costly to go to a clinic, particularly when those clinics, particularly in our area, that sort of same low acuity visit somewhere in the $200, $220 range in terms of what is reimbursed. And then again, we talked about the system savings being about 30 minutes of actual crew time instead of the significant burden that we showed above. So bottom line, Ethan has resulted, we've done Ethan almost 25,000 times since we started. Again, last quarter of 2014. So 20,000 times we've avoided the ambulance ride. So rough math would tell you that about 90% of the time we avoid the ambulance transport. And that is in stark contrast to the program I told you about that we started with, where 80% of the time that program, the old ATP program, was resulting in a recommendation to transport that patient by ambulance 80% of the time. Ethan is on the exact opposite end of that. 92% of the time, it's a recommendation that that patient does not require ambulance transport and can go safely by something else. So at least 20,000 times we've avoided ambulance trips. We know that those are at least 44 to 47 minutes saved in terms of our crew time per encounter. We know that somewhere in the neighborhood of $1,300. We recently revised some of our local regulations in terms of how ambulance services are charged. Again, that has nothing to do with what they're reimbursed, but around $1,300 is saved because there's no ambulance ride, right? There's no ambulance cost. Therefore, their patient and or their insured does not receive a bill for that. So significant savings to the patient and or the payer themselves. And then again, external, not our own, external review of our system shows that it looks like we've saved somewhere in the neighborhood of about $25 million over the life of Ethan. The complicating part is that Ethan, because we were federally funded initially, we don't have a great and sustainable funding model yet. And so I gave you some of the really significant pluses: safe, easy, fast for our crews, significant cost and efficiency savings, but we have been struggling with finding a sustainable funding model because, again, if there's no ambulance transport, then under current regulation, there's no real way for us to bill for the Ethan encounter, because prior to recent, and I'll speak about that in just a minute, there was no ability to bill for a crew, an EMS crew going out, doing an assessment, and then recommending that the patient did not require transport. We have, even though we've done Ethan about 25,000 times since we started, we know that there's probably another 5 to 10% of our daily EMS calls that could be, based on the dispatch code at least, we think could be Ethan appropriate, that we are still not seeing all of our crews utilize Ethan for those encounters. So obviously Ethan is a new program that, just like anything else, has gone through its periods of adoption and has about 70, roughly, based on our assessment of 70% penetrance, meaning most of our 70% of our crew, our personnel, have used Ethan. But that still leaves a 20-30% gap in terms of some users that we know just have either never used Ethan or have never at least activated Ethan on their own, which is a little bit different because of the way the system tracks those activations. So I know probably many of you, as I was speaking about that last part, were screaming about ET3. ET3, that CMMI's recent announcement to do a funding or proposed funding models to open the door for telehealth specifically, as well as some other potential reimbursement models that may allow for something like Ethan. Yes, all of those things are in the future. We are, just like I'm sure many of you are looking at how they fit into our own community and our own system. I will tell you and will share with you that we've had some very interesting conversations directly with CMMI, because I know that when CMMI first announced ET3, I got hundreds of texts and emails from colleagues around the country saying, hey, look, it looks like this is going to be, a great chance for you to get reimbursed for what you guys are doing. And I got to tell you, based right now, I'm not sure that Ethan is going to fit the traditional structure that at least CMMI is putting out there right now. Again, that is a larger conversation, very complicated, that I'm going to just touch the surface of to show you why. So again, this is directly from ET3, CMS's ET3 slides. This is the current model: 911 call received, ambulance service is initiated, ambulance transports to the covered destination, which is an emergency department. Or ambulance arrives but doesn't transport, in which case there's no mechanism to do any billing. The ET3 model obviously looks at, hey, is there a place to intervene? Is there alternate destinations, clinics, urgent cares, or is there a qualified healthcare practitioner that can do a treatment in place? So yes, all of these things are happening right now. The enrollment period, or application period, I should say, is open right now, and I'm sure many of you are looking at just to see if ET3 may fit into your operational system. The City of Houston, no secret, we are obviously preparing our own application. That application was today, got bumped back, and I'm sure many of you exhaled a sigh of deep breath like we did here as well, because we were still in a process of putting ours together and finalizing ours. There's a lot of unknown, a lot of questions that remain still with whether Ethan, as we operate now, would fit and qualify for any of these reimbursements. We do think there are some potential opportunities, and we're speaking directly with CMMI about how to do that. The other thing that I want to mention, and I put on that slide, is direct payer collaborations, right? So payer collaborations in terms of we are working directly with some entities in our area because they have come to us, and I'm not really at liberty to mention specific systems, but they've come to us and said, hey, you know we were spending $30,000 over a period of time for just the ambulance transports for particular patients that in this case were high utilizers, right? I mentioned Ethan was not really targeted to handle those patients, but we do know that we have handled quite a few of those. And so we've had some of those payer systems come to us and say, hey, we saw those expenses drop right off. What happened? How did you do this? Because we were getting bills for repeated ambulance transports and they're not there anymore. So we have been working with some of our payer collaborators to see if we can guide our patients, not only guide them to more effective, places of care, be it clinics, urgent cares, or emergency departments, but ET3 has opened the door for us to potentially collaborate in a way that maybe we can work directly with those payers. And we have built a system called Synapse that helps us identify, track those patients, and potentially collaborate in a way to work directly with payers for them to say to us, hey, I have this group of patients that I really care about. They could be recent hospital discharges, they could be high utilizers, but we would track those patients specifically, not an entire group of XYZ insurance company, not all of their patients, but we would say, hey, you have a subset of your patients that you care about, XYZ insurance company. We're going to flag those and we're going to help direct them to maybe just in-network urgent cares or in-network hospitals. We're going to try and help you do that, but only if they are appropriate for Ethan, right? Low acuity callers. So we're not talking about changing the entire dispatch or transport system for an EMS agency. We're talking about working with our payers to redirect these low acuity these low acuity 911 callers to clinics and urgent cares that that are medically appropriate, always focusing on the patient's safety and their ability to get safely taken care of. So that is the last slide of the presentation. I'll put this up here as my contact information. And I think I left myself with a little bit of time to facilitate some questions. And again, please write my email address. I am just getting into this whole social media thing, so you are welcome to ask me questions on Twitter as well. I'm happy to answer questions about Ethan. Ethan, I don't think I mentioned, but should have, was originally federally funded through some of the 1115 waiver projects for states that did not choose to expand Medicare and Medicaid back when the Affordable Care Act was just getting started. So we had some federal funding to get started. The entire program, when we started, cost about probably $2.5 million to get off the ground. That is a very common, frequent first question, and cost probably about $1 million, $1.5 million to maintain. So it is absolutely not the cheapest program in the world, but it is obviously not a significant cost burden when you're talking about cities of a fair scale that have budgets that are upwards in the hundreds of millions of dollars. So again, I'm happy to answer some questions now if there is time based on our moderators' concerns. And again, take my email, contact information, and I'm more than happy to answer questions offline after the presentation. I thank you very much for your attention and look forward to getting your questions.
We do have a few questions, Dr. Gonzalez. The first one asks, are EM physicians working from home satisfied with their pay rates for this service? Is it competitive? And what or how is the telehealth pay rate to the physician devised?
Yeah, that's a great question. So we looked at a variety of ways to model this, and I'll tell you that we took essentially for those clinicians that work in the emergency medicine space, we took sort of what was the average rate for emergency medicine and went kind of just below that. So I'll tell you, we are in the Houston area. The Houston and Texas in particular is one of the highest reimbursed rates for emergency physicians at the bedside. So we took in the entire state and then took a fraction of that. So essentially what we wanted to do is make sure we were doing at least as well as sort of a low acuity emergency department setting. So the exact number I probably shouldn't share in the public setting. I'm happy to discuss it further offline. But we worked on a calculation that came up with a flat rate. So the physicians are actually paid as a flat hourly rate because we wanted them to be available immediately. So what I mean by that is we had a fair number of groups come forward to us and say, hey, we will make sure that the doc who's working in our low acuity clinic area of our lowest volume freestanding ER will answer those calls for you, and we'll do it for even a fraction of what you're willing to pay. But we didn't choose those options because we know that, especially if you're in healthcare, you're going to take care of the person that's right in front of you. And if the phone is ringing, you're less likely to answer that. So for our crews, because we wanted them the physician to work in a dedicated fashion, our physicians are not able to work in any other clinical setting. They can answer wherever they want. We've had people answer from their vacations, they've answered from their home offices, if they're doing charts, like they just can't be responsible for other patient care duties while they're working for us.
Okay. Next question. I know you mentioned agreements with clinics in Houston, but do you have agreements with local urgent care centers?
No, and that is a great question. So part of the reason we did not establish initial relationships with some of our urgent cares is, number one, it might be interesting for the person asking the question to know that Houston probably still is the national leader in freestanding emergency departments. So we have way more freestanding emergency departments than we do urgent cares. None of our urgent cares in the city are 24/7. And none of the urgent cares that existed at that time were willing to take patients who did not have a reliable way to pay for that. So we tried to do some collaborative agreements. The FQHC clinic partners were willing to take subsidized payments, and some of them on a sort of a sliding fee scale for patients that were uninsured or underinsured. So I will tell you that we are working on some agreements with some urgent cares now, but when we built Ethan initially, we weren't able to successfully craft some of those agreements, particularly for patients that may be un or underinsured. So we weren't able to do that at the time. ET3 has opened the door for that discussion again, and we're actively discussing that with several different partners now.
Okay. Can or have local counties and cities contributed funding to this program?
That's a great question. We are looking again right now with some collaborations in some of our surrounding communities, because as I mentioned, Houston, the metro area is limited to a certain area, but a lot of our patients that they may commute into the city, but they live in a surrounding county, they're still our patients if they got in a minor car wreck or got called 911 from work. They're still our patients. So yes, we are looking at that right now. We have not to date had a municipality contribute, but we are working, and there will be some public announcements about some philanthropic support for our program in the coming days. So again, those agreements haven't been finalized, but yes, we are looking at some of those agreements.
I think the only other question had to do with interest by insurance companies, and I think you addressed that in your presentation. So we really appreciate you presenting this to us. This is a really interesting program. Again, this presentation has been part of the National Telehealth Resource Center's webinar series that's free and happens every month, generally on the third Thursday of the month. Our next webinar will be October 17th, and it will be Capacity Building Through Telemedicine by the Georgia Department of Public Health.
Thank you so much. Have a great day, everybody.
So at the end of this, there will be a survey, and we would really value your opinion, so please fill that out. Thank you.